Thank you for joining us. My name is Jeff DeCelles from Grassroots Soccer, and I'm representing Began Pilo Moyo and a study team from Grassroots Soccer for our work in Zimbabwe called Better, Cheaper, and More Effective, using a rapid cycle improvement model to improve implementation and outcomes on sport-based voluntary medical male circumcision demand creation in Zimbabwe. So a bit of background, Grassroots Soccer is an adolescent health organization that uses soccer or football to reach young people. And we developed a once-off intervention, or what we call a practice, to increase demand for circumcision. And in that once-off session, we have a fun, interactive educational game where the boys or the participants are playing soccer and learning about circumcision. And that's followed by a personal story from their coach, who's generally a circumcised male who can talk about his experience, and then a group discussion where the boys can ask questions and really learn kind of the answers to what motivates them. Following that once-off session, the coach then will offers to accompany the participants to the clinic to undergo circumcision. And in Zimbabwe, we've run 2 randomized controlled trials, one with adult men and one with adolescent boys, and both showed very encouraging evidence of demand creation. So after those randomized controlled trials, we really wanted to implement and scale in a real world setting. So we fortunately had the opportunity with USAID's Going the Last Mile to partner with Population Services International, PSI, to implement Make the Cut in both Bulawayo and Harare, working with adolescent boys and young men ages 15 to 29. And what we wanted to do, we didn't want to conduct another randomized control trial. We really wanted to see what worked and what didn't work in implementation. So we applied what's called a rapid cycle improvement model, where we would review monthly along with PSI. We'd look at routine monitoring data and observations to see what was working, what wasn't, and to quickly correct and try to make data-based decisions. So what we looked at monthly was total VMMC uptake amongst our participants, how many were getting circumcised, the conversion rate, which is the number of circumcised participants divided by the total participants, cost effectiveness, which is a rough calculation of what it would cost to get a male circumcised, and observations from site staff. So that included our coaches who were implementing demand creation, as well as representatives from PSI who were observing service delivery. And over the 6 months of data collection, we learned some interesting things. So from the first month to the last month, we saw an increase of VMMCs, about 23% increase from 484 to 596, which is encouraging. We saw an increase in the conversion rate. So the rate increased by about 184%, which was encouraging. We saw a slight increase in cost per VMMC generated. So we would have liked to see that go down. So hopefully we'd be getting cheaper over time, but it did increase slightly. And just to note, I think if the program would have gone on further, we probably would have seen that number come down because a lot of the fixed costs were upfront. So the training, some of the materials we had to buy, so that would have gone down gradually. But it did increase, and it's something to work on. And this figure shows a few of those indicators over time. You'll notice there is a dip in December, which is very common in VMMC programs to see a dip around the holidays and during the summer months. So not surprising. We would have loved to see a clean line keeping going up, but not surprising. Some of the innovations that we tried, so we would meet monthly, look at the data, and then try out some solutions. Some of what we tried that worked was introduction of female mobilizers. So when our numbers were initially lower than we expected, we saw some evidence from the field that female mobilizers can be as effective as male mobilizers, if not more so. And we tried that out, and it was very effective. We also brought both the VMMC demand creation and the service to men at the workplace after hours. So we were having difficulty reaching men as opposed to boys, which we were able to get somewhat easily through schools. We found that bringing the service and the demand creation at once to men at the workplace was more effective. And then an observation we had that we continually worked on was just improved communication between the outreach workers and the clinicians. So the clinicians would know when we were bringing people to get circumcised, what messaging we were providing, and just always that need to improve communication. Um, so this was our first time using the RCI meetings, and and we found them really valuable. Something we'd like to continue doing because we were able to not just collect data for publication, but to actually use it. And the next steps, because we have all these data, we're going to be able to disaggregate it and learn more. Um, we'll be able to take the data for what what worked and what didn't work for adult men versus boys. We'll also be able to look at the differences between Bulawayo and Harare, which are quite different. So we'll be looking at that. And we'd like to share the Make the Cut curriculum and kind of this process we used for making improvements more widely, because we think it could be quite valuable for anyone implementing VMMC programming. Thank you very much.